Hello and welcome. My name is Michelle Benitez, and I'm a health librarian at Stanford Health Library. Thank you for joining us for today's presentation, Discover the Latest Changes to Medicare Part D. Joining us tonight is Maha Justi. She's a volunteer at she's a volunteer HICAP Medicare counselor, got it, and is certified by the California Department of Aging. Maha has been assisting Medicare beneficiaries for the past 16 years with all of their Medicare questions. She's a retired Silicon Valley engineer who enjoys helping seniors and their families navigate complex Medicare issues. I'm going to turn it over to you now, Maha. Thank you.
Thank you. Thank you, Stanford Library, for inviting us back. And welcome, everyone. Let me share my screen and we can get going. So tonight we'll be talking about Medicare Part D changes for 2025. But I'd like to always start out by introducing ourselves. Who is HICAP? So HICAP is Health Insurance Counseling and Advocacy Program. We are part of a nationwide group that is available in every county, in every state. And our goal is to educate, assist, and advocate on behalf of seniors. Our service is free, unbiased, and absolutely confidential. As I said, it's a service in every county. And although we have a grant from the federal government, it goes as far as maybe employing 3 people. So we have an army of volunteers that basically help in every county. Tonight's agenda, no matter what the topic is, I always like to start out with an introduction, a refresher of Medicare program, so you have a better overview of what it's all about. And then I'm going to take a deep dive into Medicare Part D and what to look forward to. So when we talk about Medicare, there's something called original Medicare. And here the terminology is really important to understand. Original Medicare is this red, white, and blue card. When you join Medicare, you join 2 parts. Part A, which generally cover anything that has to do with institution, inpatient hospitalization. Part B covers doctors' outpatient services. Now, it is a federal program. When you enroll in Medicare, you go through the Social Security Administration. The reason for that is the Social Security Administration has your work history records because you need to have 40 credits, which is about 10 years of work history, paying into the Medicare FICA tax, or either on your account or on a spouse's account. So you always enroll through Social Security. Now, once you're enrolled in the system, then you are, the system is managed, or Medicare is managed by a Center of Medicare and Medicaid. We call it CSM. This is the people that actually set up the rules. So let's try to understand what is this Part A and Part B, and what does it cost involve. So anytime we talk about insurance, we talk about premium, deductible, and copay. Now, as far as premium is concerned, for Part A, which is the hospital portion, for most people that work 10 years in the US, their premium is 0. Part B, the premium is 185 for 2025. I say here for most people is because this number is income index. So later on, I will tell you how is index. So some people that would make more than a certain amount of money might pay a higher premium. As far as deductible is concerned, deductible meaning that you have to pay the first part yourself before services start. Now, in case of Part A, it's this year is 1676 for every benefit period. What does that mean, a benefit period? You go to a hospital, you broke your arm, they want you to pay that first 1676 yourself. You go home, you have no incidents, no problem, no inpatient hospitalization. You go back on 3 months later, they say, oh, your benefit period expired. So you have to start again and pay that number again. So that could roll multiple times throughout the year. Now, as far as Part B is concerned, which is the doctor's hospital, It's a flat number. That number is $257 for everybody. It's not income index, it's the first amount that you have to pay yourself. As far as copay is concerned, once you have met your deductible, the copay, basically in the hospital, co-insurance copay, for the first 60 days is zero. Hopefully nobody stays in the hospital that long, but it's zero. As far as Part B is concerned, which is doctors, it's 80-20. So Medicare, original Medicare would pay 80%, and you will pay 20% of what? Of an assigned bill. Assigned bill meaning it's the Center for Medicare and Medicaid makes contract with doctors, and it says, do we agree for this particular code? Do you agree to take that as payment in full? So you might get a bill that says the doctor would normally bill $400 for that visit, but their contract with Medicare is $100. So what you're liable for is only 20% of that $100. Now, as you could see, there are problems with this kind of coverage. There are holes, or we can call it gaps. The first problem is unlimited financial liability. So this could roll multiple times a year, and this is unlimited. So the more often you go to a doctor, the more often you're going to pay yourself. So that's a kind of an open financial liability. The second problem is it doesn't have anything to do with prescription drugs, specifically the prescription drugs you take at home. I should add that Part B does have prescription drugs that will be injected in a doctor's office, like an infusion and so on and so on. That is already covered under Part B. But anything you take at home is not covered here. So what do people do to cover these gaps? So original Medicare is not enough. So the gaps, this original Medicare is your primary insurance, which is a federal program. Then comes private insurance. The first private insurance that comes in, it's called Medigap. So see the word gap, Medigap. It's the insurance that covers the holes that these two parts do not cover. And it comes in different variety. So depending how many gaps you want to cover, then you can take coverage. So it's a secondary insurance, secondary to Medicare. It would only pay if Medicare pays. It's only a financial insurance. So this private company has zero decision making as far as your healthcare is concerned. You don't have to go to them for pre-authorization. You don't do anything with them. They're simply financial protection for these two parts. And then what happened to Part D, which is prescription drugs? So again, private companies jumped in and said, we can come from programs to cover prescription drugs. So you have federal program that's A and B, and then you have private program to supplement what is not covered here. So it's all together, these four pieces, we call it the original Medicare package. Is this the only way? It's not the only way to get Medicare. There is an alternative. And the alternative is something called Medicare Advantage. Medicare Advantage, sometimes it's referred to Part C, and it's actually not part of anything, which is really a misnomer. And Medicare Advantage it's pure marketing name. It's neither an advantage nor a disadvantage. What it is private companies came to Medicare and says, well, we can do a better job. We give us your people. We'll take them over. They're going to transition from the federal program to the private program, and we're going to offer them the service that would be offered under Medicare. Now, Medicare sets guidelines, so it's not totally out of control. But then once they have the framework, these plans have the freedom to structure their advantage plan as they see appropriate. So what are example of Medicare Advantage plan? Medicare Advantage plan, you have Kaiser. Kaiser is a Medicare Advantage plan. Alignment Health, which is a lot of the Sutter people have alignment plan. United Healthcare, ARP, Medicare Advantage, is also one of the Medicare Advantage. Anytime you see Medicare Advantage plan, you know you're in private insurance realm. So what are the characteristics of such insurance? Well, it's private. It does cover everything under one umbrella. It's typically network-based. It's the only insurance you have. So you don't have a primary and a secondary. This is all you have. So if I compare them side by side, for example, you take the US, Medicare Advantage is a regional network, so it could be something only valid in San Mateo County, or it's a number of counties. It could mostly HMO, but it could also be PPO. And a very strong feature of such insurance is you always have a primary care physician that has to give you a referral. So if you want to go anywhere else, any other kind of specialty doctor, you need a referral from your primary care. If I contrast that with original Medicare is nationwide. So you take the plan in San Mateo County, but you could free to go anywhere in the country and use that insurance. It's fee for service. Fee for service is not the same thing as a PPO plan. Fee for service is they have a contract with Medicare. There is no concept of network or preferred provider or anything. Is you can go anywhere that any doctor, any hospital that accept Medicare. And the other very important feature is self-referral. So let's say you need a dermatologist, and it's very clear to you that you need a dermatologist. You don't need to go to your primary care and wait for a referral to get a dermatologist. So let's talk about a specific example so we can see cost involved. So I picked this example of Advantage versus Original. 2025 for 75-year-old person. So no matter which side on the coverage you have, you always have to pay your premium, $185. You always have to pay that. So what actually happened when you pay that to Kaiser, you actually pay it to the Part B, then Part B turns around and gives it to Kaiser. And then Kaiser could decide if there's an extra premium you would need on top of that. The premium you pay is income index. And again, I will talk about that a little later. So either way, if you go here or you go there, you still have to pay your monthly Part B premium. So if we take that out, because it's kind of a wash between the two. Now, the second thing is the Part D copay. It depends on your medication. Regardless where you are, it depends on your medication. So if you have the same medication here or there, it's going to also be kind of a wash. So it comes down to this. You have no deductible on this side. Here you always have to pay your $257. In this case, you could have this alignment plan is $48 a month, which sounds very reasonable. On the other side, if you take a Medigap, it's like $200 a month. So people perceive that this package is a lot more expensive. In this case, the copays here, every time you get a service, you will have a copay. Now, in this case, once you pay your $200 a month, there's nothing else to pay. So you're done. So it is indeed cheaper if you're healthy and you never go to doctors, but you don't know what's going to happen down the line. So that's kind of the trade-off. And people try to, they sometimes misled, think it's cheaper, but you need to really step back and look at the full equation. If you are very sick and you use the entire maximum out of pocket, this number could go up to $7,000. This is just, in this example, is $3,900. You divide that number by 12 months, and it's certainly a lot more than the $200 that you're paying. So it really depends on your health and so on. Now, the Medicare Advantage plans include the premium for Part D, so you don't have to pay an extra premium. So if the premium is zero, it's already included in there, but it doesn't exempt you from having an IRMA. If your income is high, you will also pay this IRMA. If you are on this side, a Medicare Advantage, the cheapest plan we have in our county is $1.80. The most expensive is $183 in San Mateo County. So it really depends on what coverage you're going to need. So the moral of the story is don't be fooled by the marketing that said this is always cheaper and this is always expensive. That's not really true. So as a kind of a review for the basic part of Medicare is you can have either original Medicare package or Medicare Advantage. You cannot have both. So a lot of people would say, I have Medicare, but that doesn't tell us anything. Do you have the original Medicare or do you have the Advantage Medicare? Because they're drastically different in how they function. The original Medicare is a federal private insurance. So this part is federal and this part is private. Advantage is totally private insurance. Now, private insurance meaning they get to decide as far as if you are, something need to be pre-authorized. Original Medicare has that concept as well, but this is a lot more prevalent. Now, to note is that if you decide to go for Medicare Advantage, let's say you want to go for Medicare Advantage, there's something called a trial period, and the trial period is 12 months. If you try it and you decide you hate it, no harm done. Now, if you tried it and you stay longer than 12 months, you can go back to original Medicare. You can buy a Part D. What you cannot do is buy a Medigap. You have no longer a federal guarantee to buy a Medigap. And remember, Medigap is your financial protection with original Medicare. So this is very important. And a lot of people would come and tell us, had I known there is a 12-month deadline, I would have made different choices. There are some limited cases where you can go back to and have their guarantee back. But again, these are limited cases. And coming up in March 6th, I'm going to go into a lot of details in Medigap for another talk here. The other thing to be aware of that many of the private insurer companies sell Medicare Advantage, Medigap, and Part D. So if somebody says what insurance you have, and they say I have AARP United Healthcare, that basically said nothing, because it could be United Healthcare AARP Medicare Advantage plan, it could be a Medicare Supplement AARP, or could be a Part D plan. So again, the terminology is very important. So that section, what my hope is that you're able to look at your insurance, I identify what you actually have. Do you have the original Medicare package or do you have a Medicare Advantage? This is very important to know that as you go forward and navigate your insurance. So that was a very quick overview. Do we have any questions on that part?
Let's see. We just have one, Maha. Somebody's asking if they're turning 65 this year, but they plan on working for a few more years. What parts of Medicare do they need to enroll in this year?
I'm going to give you a quick answer to that, but I have, again, on April 10th, a full presentation on people working and joining, becoming eligible for Medicare. So the short answer is if you are working and is covered under an employer health plan, you don't have to sign in for anything. You don't need to take A, B, or anything because your employer insurance would be your primary coverage. So with the exception if you're working for a small company, less than 20 people. But typically, you don't need to do anything. And one thing to be careful about is that sometimes people look at it and say, oh, Part A is free, I'm going to sign up for it anyway. Or they're collecting Social Security and it's auto-enrolled. In these cases, what you have to be careful about with Part A, even though it's free, if you have a health saving account, there could be potential problems if you sign up for A, because a health saving account requires you to have a high deductible plan, and Medicare Part A is not a high deductible plan. So there are quite a bit of IRS type penalties you could be facing. But again, the short answer is if you are working, you need to do nothing. You don't have to do anything.
Thanks, Maha. There's just one other one. Uh, this is about that 12-month waiting period, or the period for the Medigap. After that 12 months is over, you can't get Medicap anymore. It's permanent. After that 12 months, you'll never get another chance. If you, right.
And this is true. So basically, you lose your federal guarantee. What does that mean? By law, if you go within that 12 months, or when you first become eligible for Medicare, and you go to one of those Medigap companies and say, I want a Medigap, they say, sure. They're not allowed to ask you anything. They're not allowed to ask you anything about your health. They have to give you the same price they would give everybody in your age group. So that's your federal guarantee. You would lose that guarantee for the rest of your life if you exceed that period. Um, doesn't mean they're not going to take you, but it's absolutely at their discretion. They can decide not to take you. They can decide to subject you to medical underwriting. Um, there are limited cases where you can get out of it. One case, for example, if your Medicare Advantage plan decided to leave the market, you didn't leave it, they left the market. You've been on it for 10 years and they decided to just not want to be in Santa Clara County anymore. In that case, you would get the guarantee back. Another case, if you move, let's say you are Kaiser and then you move to Colorado, they don't have Kaiser in Colorado, I think. Then in this case, you're allowed to choose again and you would have your guarantee back.
Okay. Thank you for clarifying. One other question just came in about the benefit period. Can you clarify again how the benefit period gets determined?
So the benefit period is determined that once you go into a hospital and you leave the hospital, if there are 60 days elapsed with no incident of in-hospitalization, then the benefit period ends. So it's basically 60 days. If you go back in day 61, you have to pay the deductible again. Now, if within the 60 days you keep going in and out of the hospital, and let's say on day 59 you're in the hospital, that benefit period basically never expires. You're continuously within that benefit period. But if you go out and have 60 days with no hospitalization, then your benefit period expires.
All right, thank you. We have one more. If you can take another one before we go to the next section. Thanks everybody for your questions. What if somebody works in a company that has fewer than 20 employees and they're turning 65?
In this case, because they're a small employer, then you have to sign up for Medicare, and Medicare becomes your primary, and your employer health insurance becomes your secondary.
Okay, thank you.
Actually, I don't know the exact number, whether 10 or 20, but I know it's really meant for small employer. And the other thing I should mention also that when we talk about employer health insurance, and again, I'm going to talk about it a lot more in detail in April, COBRA does not count as, or retirement insurance does not count as employer health insurance. So when I talk about you don't have to sign up with Medicare as long as your employer is providing health insurance, I'm talking about active employment, not retirement or COBRA. Okay.
Okay.
So let me move on now to the next part, which is Part D, prescription drug plan. I'm going to talk about what is what is new in 2025, but I will give a little bit of a background also so you have a context of what the implication of what's coming up. And I'm going to talk about some assistant program and also end up with our services. So just a brief history. Medicare itself was started, A&P was started in the 60s. Now, Part D came much later, came in 2003, Medicare Modernization Act. The program actually started becoming effective 2006. Then it pretty much stays the same for quite a while until the Affordable Care Act came in 2010. And if you talk to somebody who had the Medicare for a long time, there is this talk about donut hall, where if you are in this donut hall, you have tremendous expenses. The whole idea of the Affordable Care Act was to close this donut hole by 2020. In 2018, this whole donut hole thing accelerated to close it. And what I'm going to concentrate on today is the Inflation Reduction Act of 2022, which completely eliminated any gaps in coverage. And I'm going to go through that. But first, I'd like to cover some of the Part D plan basics. So again, it's covered by private companies. However, they cannot just willy-nilly decide on the rules. There are framework that is set up by Medicare, what they can and cannot do, what they have to do. And once you sign up for a plan, you're locked for the calendar year. So you cannot be switching. There are some cases, but then there are the exception to the rule. Medicare Part D covers medication that you get in a pharmacy. So as opposed to Part B, which is part of the original Medicare, it's for medication that administer in a doctor's setting, injection, infusion, doctor's office, and so on. But any pills you take at home or anything you do at home is covered by Part D. Each Part D plans have their own formulary. A formulary is basically a list of all the medication that they are willing to provide you with. Again, there are rules about these formularies. So, for example, Medicare comes and says for every disease you have to have two FDA approved common medications. So there is coverage that is assured. It might not have the specific one you want, but they have to have something that would be equivalent. They also have their contracted pharmacies. So if I go and get a health insurance plan from WellCare, they have a category of pharmacies, retail and mail order, and they put them under preferred, in network, and out of network. So basically, I have my insurance, and let's say I always go to Safeway. But if I find out that Safeway is not a preferred, then I definitely will be paying more money as opposed to going to, let's say, one of the preferred pharmacy. And the preferred pharmacy could change from year to year. And we always tell people when they come and ask us, what insurance should I take? And we go and do drug searches for them. They would say, I always like to go to Walgreens. And we say, okay, if you can cross the street and go to CVS and save X amount, would you be willing to? They would say, absolutely. I didn't even know it was an option. So be aware of this preferred pharmacy concept. I mentioned earlier that there is income indexed to some of these premium you're paying. So the income index has to do with Part B, which you pay in regardless where you are, and Part D. So what is it? What is it? So for example, if you are single or married, your Part B premium standard, if your income is less than 212,000, married, would be $185. For Part D, there is no extra money. Now, the minute your income go $1 above that amount, your premium is going to jump. So your premium is going to jump to, in this case, $259. In this case, whatever you're paying for your Part D is going to be $13.70 added to it. So for example, somebody says, my plan is $1.80. Well, great. But if your income is above this number here, you're going to pay that $13.70 regardless where you are. And you can see it goes up from there. So we always tell people to be kind of aware of this income index because if you miss it by $1, and if you can do something at the end of the year before the tax year is over, it might save you quite a lot of money. That's the first thing. The second thing is the premium, and this index thing is when it's decided, it's basically the Social Security Administration look at it and look at your income. They have a direct link to the IRS. They go and pull your record from 2 years prior, and they say, "Oh, you made over $500,000 that year. Therefore, this is the premium we're gonna assign to you." But that's the premium they pulled based on your income 2 years ago. Let's say you were retired in 2025, and that's not your income anymore. So you could appeal it. So the minute you get this additional IRMA, you look at it and you say, is my income today less than what it was 2 years ago? And if it is, then you run to the Social Security office and you ask them to review based on your current income. They're not going to give you money back. So the sooner you do it, the better you are. Let's go into the Inflation Reduction Act. I said it's 2022. So starting 2023, the first thing that happened, that vaccine, the copay was eliminated. And I know a lot of people that were taking the Shingrix vaccine were really happy because it was so expensive. But starting 2023, that was no longer copay. Insulin was capped to $35 a month. Then in 2024, there's something called extra help that is income and asset based that became more generous. What also became more generous in 2024 is once you reach a certain level phase that's called a catastrophic phase, once you get there, which is somewhere around, once you spend something like $7,000, then every medication you take, you have to pay 5% of it. And that could be really huge for people that have expensive medication. Now, fast forward to 2025. The cap is now $2,000, period. So there is no 5%, there is nothing else. Once you pay the first $2,000, you are done. So some people can meet that in the first month. I've seen cancer medication that are $35,000 a month now, which mean that in the first month, they're liable for that 2,000, but for the rest of the year, they pay nothing. As long as the medication they're taking is on the formulary. If the medication is not on the formulary, then they would have to pay everything themselves. So then it's really important when you pick a plan is to make sure that your medication are part of that formulary. The second thing that happened in 2025 is something called optional monthly payment prescription plan. What it basically said is we recognize that it could be very expensive for somebody for the first month or the first 5 months to have to pay a large amount of money, up to $2,000. So what is offered is a program that spread this amount over the entire year to make it a little bit easier as far as payment. You don't pay more or less; it's just being spread out. So let's take a little bit of a look into it. The 2,000, it's called a maximum out of pocket. So to understand this, when you take a Part D plan, prescription drug plan, it has now in 2025, it has 3 phases. Phase 1, it's called a deductible phase. So a health insurance can say, okay, in this phase, you have to pay 100% of the cost of the medication. Once you reach that phase, then the next part is called basically the co-insurance phase. In this phase, They tell you, okay, for this medication, you pay $2. For this medication, you pay 50%. For this medication, you pay X. Once you reach that $2,000, you're done. So after that, everything else is paid by your insurance. You have met your out of pocket. So to give you some number behind that, the CSM, CMS, I'm sorry, comes and says in the deductible part, you, private insurance company, cannot charge more than $590 as deductible. So you cannot have a plan that comes and says, my deductible is $7,000. That doesn't exist. The maximum they could charge is $590. They could charge zero. They could charge $200. It's completely up to them. But they cannot go more than $590. Once you met your deductible, the initial coverage limit is 2,000. Now, within this 2,000, they could structure their tier structure to say it could be 25%, it could be 25% is kind of suggested number, but it could be any other number, provided that the total of your copay co-insurance does not go over $2,000. Once you have that, then you have reached what's called catastrophic and you're done. Everything is zero. So I'd like to put an example on it so you can have a feeling of the numbers. So this is San Mateo County, and I don't think it's very different in Santa Clara County. So I take two private plans. One is called Cigna, one is Blue Shield. Now, in the case of Cigna, the monthly premium is $1.80. Now, the Blue Shield is $183.50. And often people are very kind of curious. $1.80 sounds so cheap, it must be a bad plan. And well, we don't know. Let's go further so we can understand what's a good and bad. Now, in this case, the deductible $590, and in this case, the deductible is zero. Okay, sounds good. So what happened after that? Then you go into to reach your $2,000. In this plan, it says, if your medication is preferred generic, you pay zero. If it's generic, you pay $2, and so on, until you reach the 2,000. Now, in this case, it says, well, you pay $2 here, you pay $7 here, you pay $43 here, and so on. Now, you look at these and say, gee, is this better than this one? Provided your medication is available on both. Is this better than this? We don't know. So let's go a little bit further and try to dig into a little deeper. So let's take a case where you don't take any medications. You don't take any medication and you say, oh, gee, maybe I don't need a Part D at all. And we say, well, you better have a Part D because you don't, for every month that you don't have a Part D, you will have a 1% premium penalty for every month. 1% of a standard premium nationwide is $34. So 1% every month, that would be when you go back on Part D, you decide to come back on Part D, that penalty would be added to whatever premium you're paying for the rest of your life. So you need to be aware of that. So you look at that and you say, I take no medication, and Cigna is $1.80, and deductible $590. Well, you don't take any medication, there is no deductible, there's no copay, there's nothing to pay. So all you pay for the entire year is $19.80. Now you take Blue Shield, the premium is $183.50, and the deductible is zero. So even with no medication, you will end up paying $2,202, which is the premium times 12. Okay, so let's go to the other extreme. You have very expensive medications above the 2,000 limit. The medication are on the formulary and you have done your research and you go into the pharmacy that is preferred by both. So you go here, the medication is available at Cigna, the medication is available at Blue Shield. So in this case, your limit is 2,000. You never pay than 2,000 plus the premium, because the premium is not included in that 2,000. So the 2,000 is strictly copay. It does not include the premium. Now, if you take the Blue Shield, then you're paying the 2,000, which is your copay, in addition to the 183.50 times 12. So you look at this for expensive medication on the formulary, you're paying $2,000 here, you're paying more than twice as much here. So you cannot just go by expensive, meaning it's better. Now, between you have what I call it K3. You have moderate list of medication, some generic, some brand name. They're all on the formulary. And again, you're using preferred pharmacies for both. Now, in this case, you're paying your premium, $180, and you have your deductible, $590. So depending on your co-pays, there is a question mark. Premium for sure you have to pay. Premium for sure you have to pay. Now the question is, what is the copay? Also, please note that this deductible is included in the $2,000 maximum out of pocket, and I will go through that again. So how do I know what is this amount here in between? I know I'm never going to pay that more than the 2,000 plus my premium. Now, the only way to find out is you go to Medicare.gov, enter your medication, and then you will get the actual answer. Anything else you will not be able to do, except if you call every company out there, if you're buying a plan, give every company and say, with my medication, how much it's going to cost me, which is a really tremendous task. Of course, if you already have a plan, you can call them tomorrow and say um, how much my medication copay. So as a summary for out of pocket, the 2,000 in maximum out of pocket include the deductible. So you know that whatever the deductible is already counted as part of the 2,000 and a copay. It exclude the premium and it exclude any Part B medication. Part B medication that you get in the hospital has nothing to do with it, and it does not include anything that you get um, outside of the formulary. So if you are planning to take a medication that does not exist on the formulary, you are liable for the full amount. The second thing I wanted to make very clear that a higher Part D premium does not guarantee a better plan. So forget the marketing hype. There's a lot of companies come and say, oh, I'm going to go with ARP because they're reputable. Well, if they're reputable, but they don't have your medication on the formulary, then you're out of luck. So what matters most is that your medication are included in the formulary. Everything else is really marketing hype. Without Part D plan, you could incur a penalty. So you need a Part D plan. The second part I'm going to go into before I stop for question is this monthly prescription payment plan. And the concept is pretty straightforward. It's a new idea that meant to spread your expenses over the year so people who are not able to just pay all at once $2,000 if they have expensive medication, they have the option to spread it over the year. The enrollment is not automatic. You have to opt in. And typically what happened from experience is I've seen this year, if your plan see that you have expensive medication, they will send you a note. Hey, by the way, this spreading, opting in might help you out if you are interested. So it is likely to help people that are expect to be reaching that 2,000 limit early in the year. And just in a picture, the way it looks is you go in January and you get your medication and your medication is kind of low. Then you go in February and it's pretty high. Your out of pocket is, close to $2,000. You can then say, oh, gee, this is just too expensive. I'd like to spread it out. So you spread it out over the rest of the year. Now, very important to understand that at the end of the day, whether you spread it or don't spread it, you'll never pay more than the $2,000, period. And that number also over the year is going to change. If your medication change, that number might not be $181. It's going to be adjusted, kind of smoothed out. So they take the new number divided by the month left to smooth everything out. But again, at the end of the year, you'll never pay more than the $2,000. Okay, so what happened? I keep talking about formulary and formulary. Well, things happen. You sign up for the plan, and everything was covered the year before in 2024, and you said, "Oh, my plan is good. I'm not going to change anything," which has really happened a lot. A lot of people just go on autopilot. They never check the formulary again. Um, and come January, they go to their pharmacy, and the pharmacist says, "Oh, I'm sorry, the medication is no longer part of the formulary for this insurance." So what do? You could apply for something called continuation of coverage. You're in the middle of a treatment, and you ask them at their discretion to change to continue supporting you for that medication as if it was on the formulary. You could also ask them for an exception. Please give me an exception. Again, it's at their discretion. Or you say, I really did check and somebody told me it was covered and I turned out it was not covered. It could be Medicare told you that. It could be that the private insurers told you that. It could be I told you that. Any marketing misrepresentation, if you fall into this, we can call Medicare and request a special enrollment, and we could switch you through in the middle of the year. So you have some remedies. Resources. So there are additional resources if your medication is not affordable, and depending on your income, there is something called Medi-Cal, and there's Medicare saving accounts. Typically, this is generally typical income limit, 100% to 138% of the federal poverty level, a bit higher if you're disabled. So what does that mean, federal poverty level? That number changes. So for 2025, for one person per year, it's about $15,000. So if your income is somewhere, and it changes the more people you have. So if your income is there, you could be eligible for some of these programs, would also help you with your medication. The copay would be drastically lower. Starting 2024, the asset limit was removed. Before that, they had a really small asset limit. So if you had like $2,000 or more in your bank account, you disqualify you from these kind of programs. The asset limit was removed. Another program called Extra Help, sometimes called LIS. That program is typically 150% of the federal poverty level, but it does have an asset limit somewhere around 35,000. When you come to Medicare and you say to HICAP and you say, I have problems with cost of my medication, the first thing we do is we screen you for any of these programs. There's also private programs. So private programs like Provider Financial Assistance Program. Certainly, Stanford has a program. Kaiser has a program. So, and their income limits tend to be more generous than the medical program. There are also some pharmaceutical programs, needymeds.org. You go in there, and a pharmaceutical company like to appear generous, so they try to help. So you could very well qualify for assistance. There are discounters like GoodRx. There's also foundations, grants that for particular diseases, they would say, yeah, we understand that even if you have insurance, your copay is too high, and we're going to help you with that particular copay. If you are in this situation, please reach out to your HICAP county office, and we are very happy to help. Our services, we offer one-on-one phone or in-person counseling. We assist in enrollment. So if you're confused about how to enroll in Medicare or switch, we certainly can assist you. We assist with appeal. If somebody says they're not going to pay for it and you hit a rock, then we could assist in actually drafting appeals for you. We could call Medicare on your behalf if you're an original Medicare. If you're not an original Medicare, again, you're dealing with a private company. We could certainly help you call the private company, but we don't have really that much of leverage other than just saying, hey, this is Meha, and we're a counselor with a, department, aging, California aging department, and they tend to listen a bit more. They tend to pay a bit more attention. But as far as original Medicare, we have a lot more leverage because we have a special line for counselor. You don't need even to be there. We can talk to them on your behalf without you being there and address whatever issue comes up. As a summary, our job is to educate and advocate on your behalf. There is a whole bunch of groups that basically go to Congress and try to make people really understand what are the um, problems that people are facing day to day, and to try to put things in place, bills in place that try to mitigate that. So with that, I will open it for question, but I think before questions, Stanford would like to do a quick survey.
We have a slide that's going up right now. We would really appreciate it if you took this quick 3-question survey about the session tonight. You can access it by just holding up your phone, scanning that QR code, and it will also be in the recorded one you get. So if you missed the opportunity tonight, you can go back and fill the survey for us. We really appreciate your feedback. I just want to remind everybody, if you had any questions, you can put them in the Q&A box on the bottom of your screen. Just want to say thank you very much. This is such a confusing thing, so thank goodness HICAP exists, because it's a really wonderful service. I'll jump into some of the questions we have. On that screen where you had, I think that's what this question is referring to, where you were talking about all the premiums and the income limits. Were the premiums on there, was that monthly?
It is monthly, yes.
Okay, got it. And about the Part D, so if your medication falls off the formulary during the year, so 2 questions about that. One, how likely are they to give you the exception? And 2, you can't change your Part D till the end of the year, right? I mean, you can't say, oh, I'm going to choose one that's got it now.
And this is really one of the biggest problems in Part D private insurance. They lock the formulary. So if you have a medication that is out of the formulary, the first thing they're going to happen, you have to work really close with your doctor. The first question is there an alternative? And remember, Medicare has told these private companies they have to be able to give you alternatives, right? Now, if you say, I tried this alternative and it didn't work for me, so your doctor has to make a strong case to get an exception.
Got it. All right, let's see what else we got here. Oh, this is a question I have too, because it's a little mysterious. I'm not sure if you can answer this, but how exactly does GoodRx work?
Okay, so I have to say 2 things about GoodRx. I personally always, whenever I pick up my medication, I always run GoodRx to
Mhm.
see if I can get it cheaper there, right?
Yeah,
And one of the things that for the Inflation Reduction Act, in the past, the pharmacist is not allowed to tell you, hey, Meha, there's a coupon on GoodRx that you can get this cheaper. They were not allowed to tell you that. Now the gag order has been removed, so they actually can tell you that voluntarily that you can get GoodRx. Now, if you take generics and the copay is not so high, but you still, it's your money, you want to save, by all means, use GoodRx. The only thing you need to be aware when you use GoodRx, whatever you pay does not go toward your $2,000 out of pocket maximum. So so it's completely off the books. So if you expect your medication is going to be continuously going up, you might as well keep everything in the formulary, because then you will reach your 2000 and then everything after that would be free.
Got it. Thank you for clarifying that one. You mentioned this, but you can mention it again. Somebody's asking, if you have the A and B, why do you need D?
So, because if you don't have D, first thing is you have a penalty if you try to come back into D, right? But if you never want to get back into D, and God forbid, when you're 10 years down the road, before you signed up for anything, even with paying the penalty before you sign up, because you cannot sign up um, if unless you have a particular time of the year, like during open enrollment. You cannot just say tomorrow I'm gonna have some medication, I'm gonna get that Part D signed up. So everything is you have to pay yourself, which could be devastating because I've seen medication, as I said, that costs 30,000 plus for 30-day supply. So it's a huge gamble. And that's what insurance is, to
Thank you.
prevent you from gambling your
Yeah, no gambling with that one. Let's see. What happens, okay, if you spread it out, the 2000, over the year, but then, in the middle of the year, your medications change to something cheaper, do you get money back?
basically they readjust the entire amount, so the amount paying forward will be reduced. So you will never ever, they have these complex calculation that's always adjusting. So the good news is it's spread out. The bad news is you don't know what your next month bill is going to be. But you will never ever pay more than 2000.
Okay. This is also about another question about that payment plan. Okay, so you have to complete the payments within the same calendar year, regardless of when you opt in.
Right.
So let's see, is it recommended that we opt in so we benefit from this from the beginning?
So if you opt in December and you have an expensive medication, you're going to be paying the $2,000 because there's not enough months left to spread it
Yeah,
out, right?
yeah,
So the earlier you opt in, the better off. If your medication are pretty cheap, then it might not make any sense. And
yeah,
to
yeah.
to opt in, you can opt in any time of the year. So you can opt in the middle of the year if you see your medication is getting expensive.
Okay.
But the benefit of it is, honestly, you don't know when you're going to have a condition where it's going to require you to have expensive medication. If you are lucky enough to have that problem early in the year, then you can spread it out. The later
Yeah,
you have that problem, stress of holidays, that
yeah.
you got that problem, then it's not going to be that useful.
Ah, boy, so many things to think about. Um, oh, somebody wants to know if, say, you've got multiple medications, can you use a different pharmacy for each one based on the
Absolutely.
expense? So you can, yeah.
You can. And searching to come up with Medicare.gov, to come up with the optimum plan, because um, this medication might be cheaper. I mean, the plan has to be the same, right? But the
Hmm.
pharmacies could be different. So it's very important um, to search correctly. And we have it down in HICAP to an art. So if you reach out, we can help you. If you really want to go through, most people would not bother. They would just say, okay, let's converge and tell me the kind of cheapest pharmacy for most of my medication.
Great, thank you.
And it is always the Part D providers would always try to gear you to mail order, and each one of them has their mail order service, and that is
Mm,
always the cheapest.
right. Um, I think that's it. Um, did
In the
we?
chat, a very specific question about being born in 58, lost
Oh,
their
yes.
health insurance. And for that, I would say, because there are so many different things that depends
Mhm.
on, Part D is different than the timeline. I would say call us at HICAP. Let's sit down and we can go through the detail, because sometimes it's 63 days, sometimes it's 8 months, sometimes it's 60 shorter. So sometimes you have to wait until the next open enrollment. So I don't want to just give a general blanket answer to this.
Thank you. I think we got everything. It would be great if we could get the contact info for HICAP. Highly recommend people reach out. It's an excellent free service. Thank you, Maha, for all your time.
You're welcome. So do you have that information or do you want me to share again and show that information for our
Yeah,
contact?
yeah. Can you do that? That would be super
Sure.
helpful. Thank you. I don't, yeah. So I make sure that we get the correct one.
Okay. So it should be on the screen now. You see it?
There we go. Thank you.
So as I mentioned, it's county specific because the plans are county specific. So San Mateo County, if you live in San Mateo County, you might have different plans than you have in Santa Clara County. And that's why you have regional offices. And these are the numbers where you can reach us. The framework and the service is the same, but then it's more focused and specific on your county, the plans offered in your county.
Okay. Maybe you mentioned this, and I'm sorry. If somebody is in like Alameda County, is there HICAP
HICAP,
everywhere
Alameda
in
County.
California?
Hmm?
In every county in California?
Every county in the country.
Oh, in the country. Awesome.
So we hope it's not going to get cut.
Oh my goodness, I better
So
not.
a while back, Congress said there need to be some real people for Medicare beneficiary to call and get some face-to-face service. Other than brokers. And nothing bad about brokers. Brokers offer really great services, but they also have, sometimes they have bias because they serve certain insurance companies. We don't serve any insurance companies. And some people don't feel comfortable just relying on 1-800 Medicare. So Congress said we're going to give some money to every state, and every state has to roll out a program. The national program is called SHIP, State Health Insurance Program. In California, it's called HICAP because it was the original program and they kept the same name, but that's existing in every county. And the sad part about it is a lot of people really don't know about it and they end up making wrong decisions because there's so much marketing confusion
Mhm.
that
Yeah.
they really don't get the bottom story.
Yeah. So because people view these webinars from all over the US, if they want to find out, I guess it's SHIP in the other states, is there like a website where people can go if they want to find out where they can get?
Say the word SHIP and then their county, and then Google will tell them
Oh,
exactly.
perfect. Excellent. Okay, well, I think that's everything we had. Meha, thank you so much for all this super
Welcome.
informative information. Thank you, everybody, for joining us and for all those excellent questions. If you have any other health-related questions, please reach out to Stanford Health Library. We'd love to help you. And thank you again. And
And I
good
just
night.
wanted to say that
Oh,
there are
yeah.
two more coming up. So there is
Oh, of
on
course.
March 6th, there
Mhm,
is Medigap. We're going to dive
mhm.
deeper into Medigap and what is this all about. And in April 10th, we're going to talk about employer insurance and what you can and cannot do while you're still working, and COBRA and all these great things. So hope you join
Terrific.
us.
Thank you.